Today we have a couple of speakers, but first we have our invited speaker, Dr. Stacy Marshall. She is going to talk to us today about adolescent substance use. As you can see, Dr. Marshall is Assistant Professor of Emergency Medicine at UAB, and she staffs the Alabama Poison Information Center in Birmingham. So thank you so much for joining us and for teaching us up today, Dr. Marshall. Great to have you.
No, thank you for inviting me. Like you said, I thought I'd focus on some adolescent substance use kind of issues, and I've been more involved in an adolescent substance use clinic over the last 6 months, and just kind of share some of my experiences and barriers that I've been having, and just see if anybody else is having similar issues, or if there's any like questions or concerns. So I have no disclosures or conflicts of interests. Just a little bit about who I am. So I'm actually originally from Oregon, went to school down in, or up, I guess I always forget I'm living in the South now, but up in North Carolina. I did my emergency medicine residency at Cooper University Hospital, and that's really where I got interested in toxicology and addiction medicine and treating and managing substance use disorder under Rachel Harose and Matt Salzman. So I decided to do a med tox fellowship out at UC Davis in Sacramento. I just graduated that in 2022 and then moved out to Birmingham, Alabama, where I am currently at. I'm one of the assistant professors out here. So I work in the emergency department. We run a bedside tox consult service. And then we do that both at UAB and then the Children's Hospital of Alabama, where our poison center is housed. And then more recently, I am now a part of the Division of Adolescent Medicine, where I run a substance use clinic for adolescents aged 11 to 21 about. And then I also work at the detention center kind of through them as well. So that's a little bit about where I'm coming from and my background. I'm definitely a little bit nervous giving this talk just because I am fairly new to, graduated within the last 2 years. And so hopefully you guys find this meaningful, but I am still fairly new to the field of addiction medicine, I would say. But yeah, just to give a little bit of background information, some of you guys may kind of already be familiar with this data, but greater than 90% of adults who have substance use disorders started using in their adolescence, and the earlier that you use in adolescence increases your lifetime risk of having a substance use disorder. That being said, that most youth who engage in substance use don't necessarily reach problematic levels. Inherently, any substance use in an adolescent, there is risk associated with it. And so trying to, identify those very high risk situations, I think, is important. Studies, I think that these are somewhat limited studies, but they've shown that about 5% of adolescents and 15% of young adults, so 18 to 25, meet actual criteria for substance use disorder. And then when we look at treatment rates in those groups in adolescents and young adults, it's pretty low. So less than 10% actually receive substance use specific treatment. Then when we look at a lot of the data for adolescents, so it's mainly treatments that revolve around psychosocial, so motivational interviewing, enhancement, CBT, family-based, community-based therapies. Effects are oftentimes modest at best, and then the pharmacotherapy rarely dives into adolescence, I would say, although there is much more in the kind of young adult age group, but there's very limited evidence in the adolescent age group. We're probably all familiar with, more of the cycle of addiction. And I just kind of want to bring this up because it seems very much different in adolescence, right? While adolescents can go on to, be more drawn and driven by substance use and motivated to use substance use from negative consequences. When we kind of, look at adolescents with substance use, they tend to have like a shorter history, but they develop problematic use quicker. But their problems related to substance use are often very different from adults. And a lot of times it's actually more, binge and opportunistic use. And so they may not follow this typical cycle of addiction that we may see, but it still may be very problematic and high risk use. And then kind of as we may expect is that, a lot of adolescents just don't tend to see their substance use as an issue. And so motivating them to change can be difficult at times, I would say. So any thoughts on what the most commonly used substance is in adolescents?
Nicotine.
Yeah, and so it is a little bit of a ambiguous question too. Most references will actually say that alcohol is the most commonly used substance among adolescents, but I think it somewhat depends on like how you're defining it. Is it within the last 12 months? Is it daily use? And kind of what references you're looking at. Because I've definitely seen nicotine kind of creep up there above, what the stated alcohol use rate is. But about a third of 18-year-olds report using alcohol within the last month. But alcohol use disorder is actually fairly rare in adolescents. And so I kind of look at a lot of the monitoring the future data. But again, you look at different references, you're going to find different rates that are all across the board. But yeah, so in general, alcohol, if we look over here at the left-hand side, so this is alcohol use just within the last 12 months. It's actually, been drastically on the decline over the last, couple of decades. And then daily trends, though, are much, much less, right? So kind of, when we're looking at in the 2020s and 2022, we're looking, more in single digits if you actually meets alcohol or it has daily use of alcohol use. And so it's fairly rare that, adolescents are like having regular use and are becoming dependent on alcohol, I would say. What is more common among adolescents, though, is heavy episodic drinking or binge drinking, right? And so more just like drinking very heavily on the weekends. And so this is defined as a pattern that, drinking or a pattern of drinking that raises your blood alcohol level to 80 milligrams per deciliter. And so this is going to be different for different people, obviously, but it's thought to be about 5 drinks or standard drinks within 2 hours for male and then 4 in females. And doing that 5 or more days over the last 30 days. So when we look at that data, as you can see, rates are still lower, but, it's definitely somewhat concerning that, about 1 in 10 12th graders meet binge drinking criteria. So yeah, this is the most commonly way that adolescents misuse alcohol. And in and of itself, you don't necessarily meet a use disorder, although many will still, but it doesn't necessarily mean that it's not problematic. And, we know that a lot of, fatalities and preventable injuries that happen in young adults is related to alcohol use and motor vehicle collisions. And so it's just important to remember that just because somebody doesn't have a use disorder, it doesn't mean that it's not a high risk or problematic use. So we're talking more about treatment and just kind of what is their risk, like over time, lifetime risks of developing alcohol use disorder. And so there's been studies that have shown that if you initiate alcohol when you're less than 15 years old, you're 6 times more likely of developing alcohol use disorder sometime in your lifetime. As we all know that there's no FDA approved medication for alcohol use disorder in adolescents, but a lot of times, we use things off label and whatnot. There have been some studies that have looked at naltrexone specifically in adolescents and young adults. They're not like huge cohorts of patients. They're, for the most part, generally positive, and naltrexone is fairly well tolerated. There's some mild GI side effects, and it has been shown to reduce likelihood of drinking, heavy drinking, and reduce cravings. And so even if they still go out and have these like episodes of binge drinking, they tend to drink less when they're on naltrexone. But effects are still fairly modest. And then in a lot of these studies, they weren't necessarily sustained after 1 year. So yeah, kind of transitioning to opioid use in adolescents, and just, I don't know, I'm always interested in what's happening like regionally. And so I'll present some of kind of our data from the Alabama area in the South. But, as is probably very, much so true across the country, opioid deaths are on the rise. It's largely due to synthetic opioids. And, our data, we have, a smaller population, obviously, but our heroin deaths between 2019 and 2020 stayed almost exactly the same, whereas our synthetic opioid overdose deaths nearly doubled. And that trend has continued in the Alabama area, which is, I'm sure, kind of true for elsewhere in the United States. And then, we're also kind of in the age of fentanyl analogs and novel synthetic opioids, which I know that you guys are much more, or do much more research in this area. And then adulterants and contaminants. And so we just recently tried to see like when xylazine hit, the South or the Birmingham area. And so we looked at post-mortem data, which, again, is like somewhat limited. But we didn't, so I trained up in Philly or, Cooper, which is just across the bridge at Camden. So I had very similar, illicit opioid supply as the Philly market. And xylazine was very much a thing when I was in residency training, 5-6 years ago. But in Alabama, it really like didn't hit our illicit drug supply consistently until 2021. And this is just like people who tested positive in any any overdose contributed to any illicit drug. It was almost always associated with fentanyl, which, you know, we're all pretty familiar with. And it doesn't, you know, obviously show that it was associated with, you know, fatalities or contributed to fatalities, but just its mere presence and kind of trend over time.
Do you know what that spike was in
You know, we
April 2022?
yeah, no, we don't know exactly what it was from. We don't know if it was like a high. So this is all like qualitative data too, not quantitative. And so we don't know if it was like a bad batch that just had like a really high fentanyl concentration, or potentially if the xylazine contributed to it, but it doesn't seem like, you know, the ratio of deaths seemed the same, you know, relatively, or the ratio of like how many xylazine associated deaths seem relatively the same compared to others. But yeah, we don't know exactly like if there was a substance that we weren't testing for, like a nitazine or something like that associated with it either. And then just a little bit more on some research that we're doing. This is it's the SEARCH project. It has a terrible acronym, as a lot of project names do. And I know you guys do much more expansive research in this space, but we just recently got like a small internal grant trying to look at adulterant data in our illicit drug supply and people who use drugs, and kind of seeing what is, you know, common in our area. So it's still very much in its early stages, but we are trying to, we're currently in the IRB process of identifying people who use drugs that are either in the emergency room or admitted to their hospital and have had like urine sent, and then using like leftover urine to detect if there's any like adulterants or contaminants in the drug supply. And then also like overall, we're just trying to, I don't know why that didn't show up, but that's okay. Like see what people's attitudes are towards xylazine. And so specifically if they're seeking out xylazine, if they're not seeking out xylazine, if they even know what xylazine is, because I think it is much more well known in the Northeast compared to the South. You know, in our patient population, I just don't know that it's as commonly known. And so just kind of figuring out what people's attitudes are for it. And then also we're working with our forensic toxicologists too, to see if we can test for like stability of xylazine and to know like how long does it last in urine, or does it like degrade, or kind of like what are its properties in urine, and if that's like helpful in any way for testing. Oh, it's just all there. Okay, sorry about that. But like I said, it's still pretty much in its early stages. And so we're kind of figuring out the direction of it, but we just recently got a little bit of funding to kind of help out with some of the costs related to it. But when we look at more opioid use in adolescents, so yeah, it's been on, you know, drastic decline over the last 10 years. It kind of plateaued in the early 2000s / like 2010, which is like great news, right? Like rates of synthetic opioid use is fairly low, like among high schoolers, which is awesome to hear. The problem is that opioid overdose deaths among adolescents are on the rise. Again, likely contributed to just the higher risk use associated with synthetic opioids, mostly fentanyl. And again, if they're doing more of this like binge opportunistic type use pattern, they're just at high risk for having a fatal overdose. And so even though opioid overdose use in adolescence is declining, overdose deaths are increasing. And then lastly, what I wanted to talk about is e-cigarette use in adolescents, because this is primarily what I see in the clinic. Like I do have, you know, some patients with alcohol use disorder and opioid use disorder, but I feel like anecdotally, most commonly what people are coming in with is like vaping nicotine and vaping cannabis. And e-cigarette, kind of the history of it is very interesting. I don't know if anybody watched the Big Vape documentary. It's like this 4-part series on Netflix, I think it was, but it's pretty enlightening documentary. But essentially, so e-cigarettes, they've been around for quite some time now. They were first introduced in the market in like 2006 or so. But it never really gained popularity because of a few reasons. Number one, the initial models were like very huge and clunky. And then they oftentimes utilize nicotine-free base, which is like extraordinarily irritating to your upper airways. And so people just didn't really take to it because it was so irritating, you couldn't get high enough concentrations of nicotine to really match that of a cigarette. So it was never really comparable to a cigarette. And so what happened in kind of the 20 teens is that Juul came along, and it's kind of an interesting backstory. It was like these two postdocs from Stanford that their initial intentions were actually to eliminate combustible cigarettes. Like that's what they were like touting with this plan, was that we're gonna like, fight big tobacco because, a lot of the health effects and whatnot come from, everything else that's in a cigarette rather than the nicotine itself. Although, obviously it's still a very addictive substance. But it was never really marketed at that. And we'll kind of go over that in a second. And so again, they used like a much smaller device. They developed this technology where you could create a much smaller device that was a little bit more, discreet to use. And then they figured out how you could use nicotine salts rather than free bases, which are much, much less irritating to the upper airway tract. So you can get a higher nicotine concentration. And so it matches that of a cigarette much more. And so it feels very similar to smoking a cigarette, where if you use free base, it doesn't feel quite the same. Obviously, you have to also use solvents, and those kind of potentially have unknown consequences. This is something that I'm always trying to figure out, because like a lot of my adolescents that, vape nicotine, they use varying products and varying like cartridges versus the liquid versus the pod system. It's always like, well, how many cigarettes is that? Because when you're trying to do nicotine replacement therapy, that's a lot of times what we base it off of. And kind of what I've seen is that one Juul pod is roughly 20 cigarettes. And so trying to figure out like how often they're going through a pod can be helpful. And again, it's really, great in adolescence when they're trying to use discreetly, because these just essentially look like thumb drives. And they don't have the same smell associated with it. And so they're fairly easy to use discreetly. So yeah, this is just a quote from a meeting in R.J. Reynolds among the scientists. And they said that for beginning smokers, noting that such a cigarette should be low in irritation and possibly contain flavors to make it easier for those who never smoked before to acquire the taste for it more quickly. And so that is essentially what Juul did, was they took the nicotine salt, which is very low irritation, added flavors to it, and made it, not have as many adverse associations with it when you first started using it. So it's very easy to get hooked onto it. And then when they did their initial marketing ads back in 2015, there was no marketing towards, decrease your combustible cigarette use or quit smoking. It was almost exclusively marketed towards young adults and adolescents, which was very unfortunate, because of 2-3 decades of anti-smoking campaigns had really dropped adolescent cigarette use, and this kind of undid a lot of that. So as you can see, if we're looking at cigarette use, so these are combustible cigarettes, fairly low in 2022. We're less than 5%. But if we start looking at nicotine vaping, and I've seen some studies, I don't know why this one shows that it's like so much drastically decreased, because most other studies that I've seen, it's showing that it's usually between like 25-30% in adolescents. And that kind of continues to rise. So much higher than, the combustible cigarette rate used to be. So obviously we have some, forms of treatment for tobacco use disorder. None of it is approved for kids less than 18, so they can't buy it over the counter, but they can get it with a prescription. Combinations are oftentimes more effective than a single product. And then if you combine that with psychosocial therapy, abstinence seems to be more strongly associated if you kind of do all three. And as we all know, tobacco remains the leading cause of preventable death in the United States. And back in 2014, at least, it was estimated that 5 million adolescents will die prematurely in their life related to smoking-related causes. And I think, a lot's to be seen with nicotine vaping, because we don't know what the trend is. Do they still remain dependent on it later in life, and they, become nicotine users, into their 20s and 30s. And we also just don't know the effects of vaping after, a decade, 2 decades, 3 decades. And then lastly, I thought I'd, touch a little bit on THC in adolescents. And this is stuff that I kind of learned so I moved from California to Alabama, where, Delta 9 is illegal in Alabama, and whereas it was not in California. And so we mainly saw just Delta 9 in California. which is, the primary psychoactive substance found in the native plant. But in most states where it's not legal, it's typically Delta 8 or Delta 10. So in Alabama, we primarily have Delta 8, I would say. And you synthesize that from Delta 9 or CBD. And there's a lot of other like psychoactive compounds, but these are probably the common ones that we're seeing today, at least in our area. And you guys are probably familiar with the 2018 Farm Bill that legalized growing hemp. And so hemp is a cannabis plant that has like very, very low amounts of THC, but what it does have is CBD. And you can create Delta 8 or Delta 10 from CBD. So people are making this, getting kind of around this like loophole in the law. Again, some monitoring the future data about just what is going on in adolescence. So it's kind of like plateaued. This is daily use on the left, and this is prevalence of use, at least one-time use in the last 30 days. So, fairly common in adolescence, especially as you go through high school, you just tend to use it more. But, there's still like a good proportion that don't use it at all, even though sometimes it feels like everyone is using it. And I think, the effects of marijuana use in adolescence is still to be seen, and I know that there's a lot of research going into it. I try when I talk with my adolescents about marijuana use and trying to get them in some way motivated to change. I try not to be completely lecturing of them, but I just try and bring up some points that maybe will catch their attention. And so there's been some studies that in adolescents who use heavily, it's been associated with permanent IQ loss. I've, controversially, I've seen some other studies that have shown that it may not be permanent, and then after you stop use, it kind of goes back to normal. It may, affect your athletic performance, and then there's this potential association with mental health disorders, which I think is kind of under a lot of investigation, and will be interesting to see what happens over the next couple of years. But with cannabis and cannabis use, obviously we see them in the emergency room. Sometimes they'll have these episodes of acute transient psychosis. And then as they metabolize the THC off, it clears, and then they kind of go back to normal and usually don't really have prolonged stays. Sometimes it does become more persistent, right? And so acute persistent psychosis that lasts, days, maybe weeks, but the drug has probably worn off, but they still consider that it's related to the substance. And then the bigger question is, chronic recurrent psychosis. So are these people going on to get diagnosed with schizophrenia, essentially? And I just found these studies just most interesting. Again, I think it's hard to, these are more like associations sometimes, and it's hard to, definitively say that it's a causation. This study was an adult study, so this was not adolescents, but they took two groups of patients or participants, one that was considered the control, and then this other group of participants that were clinically high risk, and it was this defined as that they were a population at higher risk for schizophrenia. So whether that was a family history or having some sort of prodromal schizophrenia symptoms. And they looked at the two groups and kind of what their response was after smoking some amount of marijuana. And so in this study, when you looked at the control compared to this clinically higher risk group for schizophrenia potentially, they were more likely to feel paranoid, they were more likely to feel anxious, and to have a little bit more of a high feeling when they took marijuana. And then over here on the right is just showing that patients who were diagnosed with substance-induced psychosis, if it was related to cannabis, had a higher rate of later being diagnosed with schizophrenia. Which is just interesting. And again, it's more of an association. We may not be controlling for the right confounders and whatnot. But hopefully over the next couple of years, we can elucidate a little bit more about that. So there is some treatment for cannabis use disorder, and there's a couple other drugs that are kind of potentially on the horizon. Nothing that's been groundbreaking of yet. But I think most notably in adolescents, N-acetylcysteine in some studies, granted these aren't really big cohorts or anything. The mechanism is still not fully elucidated, as they often aren't. But specifically in adolescents, so people aged less than 21, if you give them 1,200 milligrams of NAC BID, it's shown that it's reduced cravings and it reduces how much they use. but it hasn't really held true in adults. So I don't think it's like this slam dunk treatment by any means, but it's out there for sure. So a little bit more about what I do and like what my clinic model is so I do a half day of clinic about 2 to 3 times a month, and then hopefully as we get more patients in, that volume will increase. But it's ran through the Adolescent Health Clinic. And we have like a fairly good amount of support there. It's not designated just to my substance use clinic, it's designated to the whole clinic, but we have social work there. We have psychologists on site, so we're trying to, co-manage any mental health disorders, which is great. Like we have great access to counseling, and so we can do like, CBT and develop like coping strategy and go over those like same day, which is like amazing. What I don't have access to very easily is psychiatrists. And so psychologists can't prescribe medications. They can like help with medication recommendations and whatnot. And I can do some like initial management, but I feel like in a lot of these adolescents, their mental health gets complicated very fast and is outside of my scope of practice. And trying to refer them to psychiatry, we just don't have a lot of great, it's usually like a long wait and whatnot. So that's probably one of the biggest barriers that I have, is just getting them referred to psychiatry when they have like more complicated mental health needs. And we do like depression, anxiety screening, which is nice. And the other thing that so they also run like an eating disorder clinic. And so I get some referrals through the eating disorder clinic, and we have like an on-site nutritionist there, which is actually really great because I have like, no practice in how to treat eating disorders. And so co-managing a little bit with my other adolescent medicine colleagues has been very helpful in that aspect too. But yeah, it's very much the way we started about 6 months ago. So we've been like kind of ramping up our patient volumes and looking for like more community partners, just to get kind of awareness out there and whatnot. But our no-show rate is fairly high, I would say. And then I also work at the detention center too, which has been a very overall enlightening experience. And we also kind of try and help out with substance use issues within the detention center. So these are our main, like our community partners that we have right now. But then hoping to expand and kind of see where the clinic goes over the next months to years. But yeah, any questions? That's all I have.
Thank you so much, Dr. Marshall. And it's really cool to hear about all the different venues you're working, and your adolescent health clinic in particular sounds amazing. And it's just so cool to see, all the different hats you can wear in this business.
Yeah, it's been good.
Any questions from the group? I've got several, but I'll let the group go.
Yeah, what are you doing? What are you doing in the ER in terms of adolescent screening?
Yeah, so that's another avenue that we're looking to get into. So Children's of Alabama is their own entity. We're like physically connected with UAB, so there's a lot of crossover. But as like UAB emergency medicine, we actually don't work in the children's department. And so I'm currently trying to get in contact with them, because I don't think there is any like universal screening. I think a UDS, if it happens to get done for whatever reason, may kind of fire off a referral from there. But yeah, that's definitely another like potential great recruit like area to delve into more.
Are you seeing, I mentioned the vaping numbers that you put up there in the talk, and looks like the prevalence is going up, but are you seeing like cannabis hyperemesis in either the clinic or the ED, or referrals to the poison center in young adults going up kind of in a commensurate way?
Yeah, I don't know that I haven't had a ton of calls through the poison center. I do get called because, so I'll be on like kind of like informal call for substance use issues for inpatients. And so sometimes I do get called for hyperemesis in adolescents over at the Children's Hospital. So I don't know. I don't have a great sense because I just started a couple months ago if it's like drastically increased or not. I don't get a ton of calls right now, but I think also people just like don't quite know that we're out there. I will say that usually when they like refer, like we, try and call them beforehand, before clinic to get them to show, but those are oftentimes the patients that don't show up to clinic.
And you're treating it the same way as an adult, or do you treat it a little differently?
Oh, as far as like the hyperemesis
Yeah.
and whatnot. So GI a lot of times like manages the hyperemesis part, I feel like. So I just focus on like the cannabis part. But yeah, I mean, we'll do like, antiemetics. So we'll try like droperidol, more in like a young adult population. I've recommended capsaicin cream, but I haven't recommended that in a while, honestly. And again, I haven't done that quite so much in adolescents. It's more been young adults.
Great. Any other questions for Dr. Marshall? Oh, I'm seeing something in the chat. Dr. Reddy has something in the chat. Do you want to respond to that?
Yeah, let me see if I can.
I can read it. She said she's at the train station, so it's loud, but she wants to hear about the tools and resources you use in your clinic for youth with cannabis and vaping. Also, are all of your patients referred to the adolescent clinic?
Yeah, so we mainly do like, NRT. I will start NAC sometimes, so we kind of like see if they're a candidate for any like medical treatment. We oftentimes use the like quit line because they also have like an adolescent component to that to get them connected with a peer. And then our psychologist will do like CBT with them to try and do like coping mechanisms. And those are kind of, and then I, just try and follow them more frequently and do like recurrent, like, motivational interviewing and whatnot. But those are kind of I'm always open to suggestions because I am newer to like, treating nicotine use, I would say. I don't, we get a lot of training in like opioid use disorder, and at least like through toxicology, but I feel like we don't always get the best training for like nicotine use disorder.
Thanks for coming to speak with us today. You referred to doing this in a detention center. I'm wondering if you could speak a little bit more about your work there, how that came about, what you're doing there, and how it sort of contrasts with some of the other work you're doing based on the environment and setting.
Yeah, so it more came about because the adolescent medicine or division of adolescent medicine, they have a contract with the detention center, and so they run the medical clinic there like Monday, Wednesday, Friday. And so initially when I was doing like starting the substance use clinic, we just had very low patient volumes, and so they were just trying to fill my time. And so I was like, sure, yeah, I'll go to the detention center. But then they were also like just asking me a lot of questions about, residents there who had substance use. And so it kind of worked out well because there are a fair number of residents who use substance use there. And so it's a very different practice environment. I would say, we are able to like initiate treatment for like opioid use disorder there. And so we are, which is nice because it kind of puts them in this, defined setting that's, very well monitored and whatnot. I think it's hard because a lot of times they go to various places afterwards that may not be in Birmingham. They may go to like a program somewhere, and then keeping up with them after they get back from that program is difficult. And so I'm working with like the family court system and their case managers to try and like keep track of these kids so that when they do get back in like society and back at home, which is oftentimes in the Birmingham area but may not be, then we can try and get them connected with the clinic. The other thing that we're just starting to develop, like probably over the last couple of weeks, is just a better relationship with the family court system. And so a lot of adolescents will get, not necessarily in the detention center, but they'll get placed on like drug court. And oftentimes that mandates substance use treatment, which is very like limited in our area. So as far as I know, like I'm the only provider, and I'm like actively looking because I would love to have a colleague to like just bounce ideas off of and whatnot. But there's no other provider in Alabama that I can find that regularly prescribes like medication for addiction treatment in adolescents. And there's a few like group like counseling and like group settings that will focus on adolescents, but none of them are necessarily doing the medication side of things. And other than that, it's kind of, pediatricians aren't the most comfortable with it. Some psychiatrists will, but nothing that's been like kind of seen across the board. And so we've been trying to get connected with adolescents who make it to the drug court system to have it be like a part of their treatment for that. But yeah, it's definitely like a different population, right? Because it's not necessarily like a treatment seeking population. And so their motivation to stop can be variable, but sometimes, you know, they really are motivated to stop. And the other kind of like, you know, interesting facet of it is with a lot of these like, or I guess like one other avenue that they also kind of refer through is the school system. And so some school systems in Alabama actually have their parents sign a consent form, and they'll do like randomized drug testing on adolescents, which is like, when I heard this, I was like, what? That's insane. And so sometimes they'll get like referrals to like from that, but again, it's not necessarily like treatment seeking adolescents. It's just like part of this like process. And then there's like punitive, like they can get like punishments for having like a positive drug test, which is also just like a really interesting approach. But yeah, it's definitely like a different like patient relationship sometimes, I would say, that I'm still like kind of navigating and figuring out.
Well, in the interest of time, we're going to have to shift gears, but thank you so much, Dr. Marshall, for talking to us. And we're going to look forward to seeing you get your search study off the ground. And it's just so great to hear about all the different things you're doing. So thanks so much.
Yeah, thank you for having me. Appreciate it.
Awesome. All right, so we're going to switch gears a little bit, and I'm going to welcome Dr. Lugassi to the stage here.